Good morning, everyone. I'm happy to be here. I just got off the plane from Germany, so number one, I'll try and stay awake, and number two, all my nice shirts were already dirty, so forgive me for being so casual. But we're going to talk about tethered spinal cord today, and particularly how it relates to the myelomeningocele population. But spinal dysraphism is sort of a more broad term, and it can include occult dysraphism, and by that we mean it's more hidden. It's not so obvious as a myelomeningocele is. But there are differences. Obviously, the myelomeningocele is obviously present at birth. It does involve some neurological elements, and deterioration may occur. And it involves multiple systems, not just that placode on the back. Occult dysraphism is also present at birth, but it may not be apparent. It can occur later. Its progression is typically more slow. So I just put this up to sort of compare, give you an idea that sometimes people get confused when we talk about dysraphism, but today we're going to spend most of the time talking about the myelomeningocele itself. But there are lots of cutaneous markers that occur on patients who have dysraphism, and the ones I'm putting up here now are really associated with the occult dysraphism. You see a hairy patch. The one in the upper left is obviously a myelomeningocele, but the ones that are occult usually have what we call a cutaneous marker. Whereas I can look at the back and see something suspicious that we call a cutaneous marker, and I can say, well, you really do have occult dysraphism. Obviously, sometimes it's more obvious, as in the myelomeningocele. Myelomeningocele is considered the most common serious birth defects that we see in our society. I think most of you know it's due to a failure of the closure of the neural tube. The neural tube starts out as a flat piece of tissue, and eventually folds to become a tube, and then differentiates at the upper part into the brain and the lower part into the spinal cord. Myelomeningocele can be associated with some different brain abnormalities as well. It's unusual for occult dysraphism to have those associated brain abnormalities, whereas it's not so uncommon in myelomeningocele. And it's extremely rare for occult dysraphisms to have hydrocephalus. Myelomeningocele patients have a cord that's tethered at the side of the original placode. I guess I should back up for just a moment and explain to you that I'm taking my remarks today from a presentation I've given to some medical professionals. So I'm hoping that I translate the terms in a way that you can understand, but don't be afraid to raise your hand and ask me if you don't understand. But by the nature of the open myelomeningocele at the side of, usually the lower back, there's going to be scar tissue. So tethering is present. But from a practical standpoint, we refer to tethering as the progression of symptoms. Even though all those cords are technically tethered, that is, they're sort of held in some scar tissue, not all of them get worse. And so when we refer to tethered cord from a clinical standpoint, we usually are referring to someone who is getting worse in terms of their neurological function. So questions we'd like to cover today is, what is the clinical presentation of a tethered cord? What are the diagnostic studies that we need? Can we do some things surgically that minimize the risk of retethering? And what about retethering itself? Well, from a presentation standpoint, there are a number of symptoms that patients might have. We'll talk about these individually just a little bit, but it can be pain, it can be orthopedic difficulties, it can be a curving spine, scoliosis, there can be bowel and bladder issues, you can have motor weakness, sensory changes, you can have abnormalities progressively worse of gait. You can even have some upper extremity problems related to a tethered cord. It's a team approach. As you know, if you come to, or when you come to the spinal the clinic, you can see the orthopedist, the neurologist, the neurologist, the neurosurgeons, the physical therapists, the psychologists, the members of the team that help us come together to make decisions about how to best care for you or your loved one's situation. And part of that is documenting what we see. That's what we do when you're in clinic. Well, let's talk about pain. Pain as a symptom of a tethered cord. Pain of a tethered cord is actually quite classic. It's pain with activity. In other words, you're actively doing something and it makes your back hurt. Now that may just be using your chair to get around a lot. It may be walking. It may be doing a lot of standing or a lot of sitting. But mostly it's activity, and as soon as you stop, it gets better. So let's say you're able to walk. You're using your crutches or whatever, and you're walking, and then your back really starts to hurt. So you stop for a minute, and it gets better. And then you get going again, and it hurts, so you stop again, and it gets better. You're always stopping for a moment because it makes you better. And we call that claudication, neurogenic claudication. But it's a very classic kind of pain for tethered cord. So if a patient starts to tell me that that's the kind of pain they're experiencing, I usually can relate that to some of the early signs of tethering. Now, it's unusual for that pain to be radicular. It's unusual to go down your legs, although it can. Most of it is centered in the back. So when you come to clinic, you're probably aware that we always ask you about pain, and we're looking for that classic kind of pain to alert us to tethered cord. There can be orthopedic problems, progressive foot deformities. It can be one sign of tethering. There are obviously other reasons why that might occur, but that's one of the things we look for. Sometimes if the foot deformity is the only real thing that's going on, we might say, let's let the orthopedists do their surgery, and if it won't stay done, then that's another sign that tethering is probably the underlying cause. Scoliosis, curving spine, is one of the things that we see. A progressively curving spine is concerning. This is sort of old data, and I'm sure there's new numbers that we could share, but it's a general ballpark. If your spine deformity is less than 35 degrees, if your scoliosis is less than 35 degrees, you've got a pretty good chance to improve. Once it gets to around 50 degrees, your chances are now about a third. And once it gets beyond 50 degrees, it's not likely to improve. And by improve, I mean, let's say we untethered you. If we do it early, you have a better chance of the curve improving than if we do it late, when it just doesn't seem to be as effective. But a progressively curving spine is one of those things we watch for. And likewise, bowel and bladder dysfunction, it can be what we call upper motor neuron, meaning it's more like the injuries in the spinal cord, and your bladder as a result is tight. It's a small bladder, it's spastic, and there's not a lot of volume in it. Or it can be a lower motor neuron, meaning it's the nerves, not the spinal cord, in which case your bladder might be larger than normal. So there's a variety of ways in which the bladder might present itself. We like in our clinic again to document what we're finding. We'd like you to tell us if there's any changes in terms of continence. Sometimes medication is all we need to do to make a big difference. But if it's not helping, we also need to know that. And the typical patient with spina bifida, they have a typical, what's normal for them. Let's say they're able to catheterize and stay dry for 4 hours. And now they can only stay dry for 3 hours. And now they can only stay dry for 2 hours. So things are getting worse. And that's very suggestive that tethering is the underlying problem. Because we have even though the bladder was not normal to start with, it had its own level of function, and you're losing some of that function, and you're losing some social continence, which is so important. So we like to document changes there. Sometimes we want to do urodynamic testing, because that can give us something to look at, some data. And again, it's usually abnormal, but sometimes we like to compare it now and compare it again in 3 months or 6 months and see. It should not be progressive. And really, I guess with all of my remarks today, one of the things I'm trying to impress with you is that even though you might have a spina bifida and a certain level of neurological involvement, you should not be getting worse. So if you're getting worse from a neurological standpoint, there's usually an explanation that we can try to address. Likewise, we want to know about motor and sensory function. This helps us make decisions about tethering. So we're asking histories about strength. We're documenting our strength. If you're familiar with clinic, you know that we do the manual muscle test a lot. And surprising, that is very reproducible. We do it now, and we do it in 3 months. We can document changes. And we have a method of doing that, and even though it may be a different examiner, it's really very reproducible. So we'd like to keep track of that. I also like to include the upper extremity testing. In the typical spina bifida patient, they may have a lot of weakness in their legs, but we do not want them to get weakness in their upper extremities. And so if we're seeing some change there, that's a serious concern. And sometimes the tethering itself can do that. The tethering can be so tight that you start to lose strength in the hands. And simply untethering is all that needs to be done in many cases to correct that. Sensory levels, again, you have a baseline sensory level. If that level is changing, rising up, as we say, getting higher, becoming more involved above where it's supposed to be, then those are things that we watch for.
What exactly do you mean by sensory? What exactly do you mean by sensory? Well, mostly it's numbness, a
loss of sharp sensation. It's often not it's not like a stocking where all of a sudden everything is different. It can be patchy here and there. What's most important is to know what's normal for a given person and then how that might be changing. From an imaging standpoint, we can do plain x-rays, CT scans, magnetic resonance imaging to help us with our diagnosis. This plain x-ray shows spina bifida. You can see the wide part of the lower spinal canal there, and the spinous processes, that part of your spine in the back that you can feel sticking up, those little spines, they're gone down there. They probably were gone from birth, but you can see how wide that looks. And then also curving spine. This patient has scoliosis, something that we keep an eye on. This patient also has a hemivertebrae. You can see where that upper arrow is. There's kind of a triangular shaped vertebrae. And that in of itself can lead to scoliosis. So it may not necessarily always be tethered. It might be other things that may be participating. CT scans show us sometimes about the same thing. It's obvious we can see the spina bifida, the abnormal vertebrae. Diastematomyelia is a fancy term, but it really means a bony spicule that's sticking from the anterior part of the spine all the way through the spinal cord to the back part of the spine. And it's not rare for spina bifida patients to have diastematomyelia. So that's one of the things we look for at the time of closure of the Myelomeningocele. Split cord malformation is basically a term for the same thing. You can have the split cord without the obvious bone sticking through it, but there's usually soft tissue or something else that goes through there. But the main study in a population of patients who have spina bifida is our main ally is the MRI. And with it we can see things so much more clearly. We see the tissue. We don't see the bone so well, but we see the tissue quite well. In the lower right-hand corner there, that image it's a cross-section, front to back, across the lower body. I don't know if you can appreciate there, but there's it's a split cord. There's two spinal cords in there. So imaging, MRI imaging can give us a lot of detail that the other images don't. But it's really important to look for other things. If we're recommending a detethering operation, then I really want to know, what are we getting into? Is it simply scar tissue, or do we have? Is there a diastematomyelia? Is there lipoma? Is there fat there that's causing part of the problem? There are several things that can go on that can complicate the surgery. So the MRI can be so helpful in helping us differentiate what we're getting into. And shunt malfunction is one of those things that can mimic a tethered cord. Shunt malfunction can mimic anything. So it's always one of the things we like to be sure of is that the shunt's working, and that's not the underlying cause. It's a whole lot easier and infinitely safer to revise your shunt than it is to do the untethering procedure. I mentioned the upper extremity problem. It can be from a tethered cord, it can be from a Chiari. Sometimes it's hard to sort the two out. but I would venture to say it's from the tethered cord more often than it's from the capillary. Now, are there things we can do to minimize tethering? When I started in the beginning, I told you that everybody has a tethered cord if you have spinal bifida. And that's true. There's scar tissue from the closure of the myelomeningocele. The question is that going to be aggressive? And are there things we can do that makes it easier when it comes time to untether? Well, one of those things is to look for other reasons, other causes. We talked about that briefly. We want to, at the time of the initial closure, we want to look, see if there's anything else that might be causing some more problems, some more tethering. One of the more common is where the spinal cord comes out of the spinal canal and then becomes that open neural tube. At that point, where it comes out of the spinal canal, it's not uncommon for there to be a very thick membrane sort of constricting around the spinal cord. So it's important to cut through that so the cord is free, not constrained. The phylum terminale is a fancy term for a little thing that occurs at the very tip end of the spinal cord. And it too can be thick and contribute to tethering if it's not cut. And so at the time of the initial spinal closure, we look for those kinds of things. So I think I kind of just said all this, but we look for other things. Now I want to show you a small video of closure. This is the new myelomeningocele, and this is the open plateau that you see here. This is where it comes out from the spinal canal. The head's up that way, and what I want to do is free it up around the edges. So eventually I want to fold it up and make it more like a neural tube. Now you can see I'm cutting some pieces of skin with it right now. It's important to cut all those off eventually because they'll form a little germline if you leave them. But I'm just cutting around the edges. I want to free that plateau so it can be closed.
So is this a closure or repairing? Closure.
See how flat that plateau is? That's a myelomeningocele. It just failed to close. Failed to make a neural tube. So I'm just going around the edges. Now we're ready to start closing. That's coming together, forming a neural tube. Now, what's the advantage of this? It's not going to make it work any better. The abnormality is already there. The huge advantage to this is if we have to go back at some point in the future and untether, then we have what looks like a normal spinal cord. It's a tube and work around it. If you leave that plateau wide open and it's just closed up under the skin like a big flat piece of tissue, then it's really difficult to untether because the scar gets down into that plateau that you saw, and it's much more dangerous to do So the placo's been closed. Now, when we come back a few years from now to untether this, if we have to, it's going to look like a spinal cord. It's going to look pretty darn normal. And it's going to keep our orientation from a surgical standpoint. Now, I'm closing dura. The dura was also splayed out. So I've got the dura. I'm starting to close dura. See, the dura's coming together.
I can watch horror movies, but
And that's about as bloody as a spinal bifida case ever is. Just a little news here and there.
I'm wondering if all surgeons believe that platinum should be closed because, for 14 years, and he was back east. Can I pretty much guarantee that they did that for my son or not?
Probably. I think most of these are done by pediatric neurosurgeons now, and I would be very surprised if it wasn't that way. We learned to do this when I was, I don't know, my first 5 years of practice perhaps. It was just becoming an idea that we started doing. So